Hi, my name is Lisa and I'm doing my case study on an abdominal aortic aneurysm. For patient history, this was a 78-year-old female that presented to the ER with abdominal and back pain. She had a history of hypertension, renal failure, and was on dialysis. She was also a smoker. Her blood pressure was 190/104, pulse was 98, respirations 24, and temperature was 36.9 degrees Celsius. The image findings were an infrarenal large abdominal aortic aneurysm. Iliac and femoral vessels are patent with diffuse atherosclerotic calcification, a calcified stone in the gallbladder, and then both kidneys are atrophic with a 6-centimeter cyst arising from the upper pole of the left kidney. The most common cause of aortic aneurysms is hardening of the arteries, which is called arteriosclerosis. Arteriosclerosis and atherosclerosis can weaken the aortic wall, and the increased pressure of the blood being pumped through the aorta causes weakness of the inner layer of the endothelium. These tend to occur in white males over the age of 65. Aneurysms start to form at about age 50 and can peak around age 80. Men get these 4 to 5 times more than women do. Women are less likely to have aneurysms than men, and African Americans are less likely to have aneurysms than Caucasians. Rupture of an aortic aneurysm is catastrophic or even lethal. There are different types of them, including an ascending aneurysm, a thoracic aneurysm, and an abdominal aneurysm of the descending aorta. These can be classified as either tube-shaped, called fusiform, or round, called saccular. Most abdominal aortic aneurysms produce no symptoms. These mainly are discovered incidentally when an imaging test of the abdomen is performed. Pain is the most common symptom when an aneurysm expands or ruptures. The pain often begins in the central abdomen and radiates to the back or flank. Other symptoms can occur depending on where the aneurysm is located in the aorta and whether nearby structures are affected. Abdominal aortic aneurysms can remain asymptomatic or produce minimal symptoms for years. However, a rapidly expanding abdominal aneurysm can cause sudden onset of severe, steady, and worsening middle abdominal and back or flank pain. A major risk factor is smoking for aneurysms. The CDC reports that smokers are 3 to 5 times more likely to develop an abdominal aortic aneurysm. Collagen vascular diseases that can weaken the tissues of the aortic walls are also associated with aortic aneurysms. These diseases include Marfan syndrome and Ehlers-Danlos syndrome. Some other causes include trauma, particularly with lifting, vasculitis, congenital vascular disease, cystic medial necrosis, and post-surgical anastomotic disruption. Abdominal aortic aneurysms gradually expand over time. The larger the aneurysm, the greater the risk of rupture and death. Aneurysms measuring over 4.5 centimeters require a surgeon review for potential repair. Anything below that size can be monitored regularly through ultrasound or CT. Aneurysms rarely become infected while in the monitoring stage. Since aneurysms are associated with atherosclerosis and plaque along the aortic wall, and since aneurysms often contain a clot, debris can travel or embolize into smaller blood vessels and cause symptoms due to decreased blood flow. Some more complications include pain, spontaneous dissection, and rupture leading to hemorrhage. There are approximately 45,000 surgeries performed annually to prevent a rupture. This shows a great representation of the two options to fix an aneurysm. Image A is showing a synthetic graft, and image B shows a covered stent over the aneurysm. Whichever treatment chosen needs to be tailored to the individual patient and will depend on the location, size, and shape of the aneurysm. Here is a transverse sonogram image of an infrarenal abdominal aortic aneurysm, showing the full diameter of it around 7 centimeters. A thrombus can be found within the same area a lot of the time, like you see in this image here. A normal abdominal aortic diameter is around 1.5 to 2.5 centimeters, and when it starts to measure over 3 centimeters, it can be considered an aneurysm. So according to the chart shown here, the diameter is almost 3 to 4 times its normal size. Here, I wanted to show where the aneurysm is located through the modality of CT, just so it can clearly be seen up to scale, with the aorta showing on the superior and inferior portion of the aneurysm itself in the picture on the left, and in the picture on the right, it is shown in full. This aneurysm arises below the renal arteries and ends at the aortic bifurcation. The typical area for them to form is inferior to the renal arteries, which in this case is why it's called an infrarenal abdominal aortic aneurysm. This is showing a long axis of the descending abdominal aorta, with the aneurysm being measured out in the image to the right. The image on the left shows the color Doppler through the aneurysm. You can see that there is significant turbulent blood flow through the portion of the aneurysm, with a large thrombus on the inferior portion of the vessel itself. In the CT image on the left, I marked with the yellow arrow and wanted to show the superior portion of the aneurysm as it begins from the aorta around the level of L3. On the right-sided image, it is the slice showing its full diameter of 7 centimeters. This patient also has a 6 centimeter cyst arising from the upper pole of the left kidney, marked with the green circle, that I thought was also interesting to see in these images. Again, I wanted to show this in CT as well, just so you can really get a good idea of what it looked like compared to the rest of the surrounding anatomy. The differential diagnoses for an abdominal aortic aneurysm can include a perforated peptic ulcer, acute pancreatitis, an incarcerated hernia, nephrolithiasis, and gastritis. Here are all of my references.